And good morning, everyone, and welcome to Internal Medicine Grand Rounds. And we are very pleased today to have a focus on mentorship from a group of people who have been doing this and doing this well for quite a long time. As a department chair, it's one of the things I really valued and try to go through our department and see who was doing the most in terms of mentorship. And it happened to be our GI people. And I'm so glad that they're going to share so many tips today about it. We will be hearing from Dr. Stephen McClave, who will be introduced by our first speaker, Dr. Craig McClain. They are both professors in gastroenterology, and Craig McClain comes to us doing his formal introduction from Earlham College and University of Tennessee for his BA and MD. He went to University of Pittsburgh for internship and residency, a Minnesota Golden Gopher for GI fellowship, and he worked his way through University of Minnesota and University of Kentucky, and he has been here at University of Louisville for quite some time. Obviously, he's a full professor, and he is our academic chief and research chief in GI. For that division, and he is a world-renowned researcher with a massive number of publications and R01 grant funding, professor of not just medicine but pharmacology and toxicology, and he's the chief of research affairs as well. He is an associate vice president for health affairs here at University of Louisville, and associate vice president for translational research. He directs our clinical trials unit and our liberal research program, and he is a distinguished university scholar. And he's going to start us off talking about the value of mentorship in advancing clinical practice. Thank you, Dr. McClave.
Thanks, Dr. Williams. So I'm actually going to introduce Steve McClave. So Steve and I actually both were born in Ohio. He was in Columbus. I was the little town Granville, about 30 miles east of Columbus. So when Steve got out of his GI fellowship, I was head of GI at the University of Kentucky. And so it was a competition between UK and UofL to recruit him. And it ended up in a bidding war, and I thought we had him. And then they introduced him to his future wife over here, and I couldn't compete with that. But Steve has had a career in mentoring, and he's going to tell you about that today. And one of the things that I'm most proud of what he's done is the Nestle mentoring program, where it's mentoring people in nutrition. I'm sure Dr. Williams would tell you there's not enough MDs that know enough about nutrition. And so Steve has done a wonderful job of trying to educate us, and he's going to talk to us today about his career in mentoring. Steve.
Thanks. It does excite me to talk about mentoring because it's been such a big factor in my life. 15 years ago, we created a nutrition fellowship and called it the Nestle Mentor Fellowship. 2 years ago, our National Nutrition Society, FASPEN, created the Boost Bistrian Mentorship Award because they thought mentorship was so important. And this year I was actually the recipient of that award, and it comes with it, you have to give a talk. And so as I started reading the literature and putting this together, it made me wonder about three questions. Who have been the mentors in my life that steered me the most? Number two, was I a good mentee? Was I receptive to their input? Did I show my appreciation for the energy they put into the relationship? And then finally, if I found myself suddenly in a relationship and somebody was looking to me as a mentor, was I pouring energy into that relationship and making their pathway easier? These are the objectives. I'm going to talk in the first half of this 15 minutes, talk about the personal and professional benefits that can be achieved through a good mentorship experience. Provide examples of qualities that make for a good mentor and the qualities that make for a good mentee. And then finally, learn why mentorships are important for clinical practice. And then Craig will show how it's important for research productivity. These are my disclosures, and besides the potential conflicts of interest from industry, I do need to point out one, and that's the Nestle Mentor Nutrition Fellowship. I still call it the Mentor Fellowship. Nestle just calls it the Nestle Nutrition Fellowship, because I'll discuss that. But I'm going to give examples through this talk of my experience in critical care nutrition. But as you sit there and listen to this, mentorship transcends all disciplines and interests. And think about somebody that in your training that took extra time to steer you in the right way, or a supervisor when you started your first job that really took a special interest in you. So it applies to your life as well. I want to comment that I'm going to miss recognition of many of my mentors and mentees right here in Louisville. And the reason why is I had for time, I just selected examples that tease out these aspects of mentorship that are important. I'm going to start with this story because it's so amazing. Jeff Ponsky was a surgeon that came out of training in 1976 at the Case Western University Reserve in Ohio. He was a surgeon, but all through his training, he was interested in endoscopy. Now, the endoscopy at Case Western was run by the medicine gastroenterologists. And we all know there's a stupid competition between surgery and medicine. So he comes out of training and he goes to these gastrologists and says, would you guys teach me endoscopy? And they said, no, we don't train surgeons in endoscopy. You need to stay in the OR and we'll do the endoscopy. And they said, you'll have to find your own teacher. So you were discouraged, but sure enough, 30 miles away, he found James King, a private practice gastroenterologist in Canton, Ohio. And for 5 months, he drove there every day, spent 8 hours. And at the end of 5 months, he had accrued enough procedures to qualify for credentialing in endoscopy. So he goes back to the Cleveland Clinic endoscopist and said, okay, I've got the cases. Will you certify me in endoscopy? And they said, sure, but you can't use our equipment. So he goes home that night and he's just devastated. And they're sitting there at the dinner table. In the middle of the discussion, his mother-in-law gets up, walks out of the room, comes back in with her purse. And she goes, how much does one of these darn endoscopes cost? This is 1976. He goes, $5,200. She gets out her checkbook and writes him a check for $5,200, hands it to him, and says, here, buy your own damn scope. This is a picture of his first endoscope. And this is all documented in our Journal of Gastrointestinal Endoscopy. If you don't recognize this name, this is the guy that developed PEGs, percutaneous endoscopic gastrostomies. This guy has been an all-star. He just retired 2 years ago. He went on to be president of our endoscopy society, president of the Surgical Endoscopy Society, over 300 publications. He cemented the role of surgeons in endoscopic research and practice. And his paper that introduced the PEG was 5 years after this interaction with the gastrologist back in Case Western. My point of this story is he was the ultimate mentee. He was going to be a star, whatever he did. He was bright and energetic, full of ideas, and made things happen. These endoscopists missed the chance to mentor him. They would have made his pathway a little bit easier. He could have gotten there faster, and their careers would have benefited as well. They're kind of remain in obscurity. Jeff won't name them now. And I don't know of anybody at the time in endoscopy from Case Western on our side that reached any kind of notoriety. So what is mentorship? We all know this basically. It's a more experienced professional, a mentor that helps somebody newer in the field, a mentee, to grow and both really grow professionally and personally from a relationship. It's a selfless relationship guided by the wiser, more experienced individual, but it's non-hierarchical. We're not talking about a smart guy and a not so smart guy or haves or the have-nots. It quickly becomes a level playing field and becomes bidirectional. It's differentiated. If you look at definitions, a teacher just dispenses information. A supervisor gives trainees sufficient evidence and tools to get through the training program. But it's like a Venn diagram. And we've all had the experience where a high school teacher took special interest in us, or somebody when we started our first job really pulled us aside and made our lives easier. Why is mentorship important? Well, 15 years ago, my best buddy, Bob Martindale, a surgeon out in Portland, Oregon, he and I were having dinner with two Nestle dietitians, Cindy Lowen and another dietitian. Cindy Lowen is here in Louisville. And we were griping about too few physicians in nutrition. And they said, well, why did you go into nutrition? And simultaneously, we both said a mentor, somebody in our careers that we revered, that we liked, made it fun and interesting and challenging, and it just hooked us. And so they said, well, we got to try to recreate that. So that's what made us develop this Nestle. I still call it the Nestle Mentor Nutrition Fellowship. 15 years later, we have 5 faculty. Over 80 fellows have come through this program, and most of them are faculty members in an institution where somebody says you're going to run the nutrition program, and they kind of scramble to get training. Here at UofL, we've had Matt Bozeman, Keith Miller, Chris Jones, Enishaw Omer, Keith Miller have come through. Ted Dryden have come to the fellowship. We did a bunch of things right. We have electronic curriculum that gets updated all the time through the year. We made it 1 month duration. It's an intense immersion course, but that 1 month allows a faculty member to leave and go back home without too much disruption with family and practice. We developed slide sharing. If you got to give a talk on nutrition cancer, you get on the phone, an hour later, you got 5 talks on nutrition cancer, and paper writing. But the number one priority of this fellowship was the personal relationship. We wanted to get to know them. We wanted them to know our wives and our kids. And that personal relationship is what cemented this program. And Bob and I both feel that that our greatest academic achievement, the thing we're proudest of, is this fellowship. This is a picture of my family growing up. You hope in life that your first 2 mentors are your parents. And while that always doesn't happen, in my case, I hit the Powerball jackpot. This is my mom and dad. My dad was a pediatrician on the faculty at Ohio State. This is my older sister, Princess Kathy. Mom had a tubal pregnancy and lost 5 years. So they said, well, if we're going to have a family, we better get going. So these are, this is me here, and then my 2 younger brothers. As a kid, this is a picture of me in the 1st grade. And at one point you had to write, what am I going to be when you grow up? And it's that big line paper and the giant pencil. And if you look real closely, I've written above my head, 1st grade. And when I said what I want to be, I said, I want to be a doctor. And I just skewered the spelling. I don't remember ever saying to my dad, I want to be like you, you're my mentor. I never said any of that. I just knew I wanted to be a doctor. This is 9th grade, those most likely to be business, those lists. And here I am, most likely to be a doctor, Steve McClave. I don't remember saying to anybody that I wanted to be a doctor, but all my friends and classmates just knew that that's what I wanted to do. Unfortunately, my senior year in high school, my dad passed. He had a pulmonary embolus. So as I started to head off to college and pre-med and hopefully on to medical school, I had lost my most important mentor and was kind of struggling. This is my picture my sophomore year in college. By this time, I lost my mentor. My high school girlfriend had dumped me. And I got my first C in a chemistry lab. And I was really getting nervous. And the same week I got the C, they announced that we were going to meet with our pre-med advisor. This is at Miami University in Oxford, Ohio. This guy was a botany professor. And instead of meeting us one-on-one, he agreed to meet all of us in a room. So we go in this room at 4 o'clock in the afternoon. He walks through the crowd, walks up to the chalkboard and writes GPA, grade point average, 3.88. Now I'm sitting there with all the other eager beavers and I got a 3.56. And he turns the crowd and he says, if you don't have a 3.88, he says, you're wasting your time and you're wasting my time. You're not going to get into medical school. Well, it turned out by the time I graduated, I had worked as an orderly in a hospital there in Oxford Hospital, Oxford, Ohio. Still had a 3.56, and I got accepted to 3 medical schools. So this guy was dead wrong. And my point was, this was not a good mentor. He should not have been in charge of young people trying to get ahead in their careers. At the time, I went by Steve McClave, but I felt like a lost ball on high weeds. And when I came out of this meeting, I called Mom and I said, Mom, we're going to have to go to Plan B. Plan B, I was going to go out west backpacking and do research on grizzly bears. How do you choose a mentor? Well, most of the time you're looking for somebody with similar interests as yourselves. And it's a little bit like dating. This is a picture of the dating game, if you remember that show. And you pick somebody that you envision in yourself. And if it occurs at the right time, in the right place, and it's starting to click, you want to pour energy and nurture that relationship. You got to be careful who you pick. You don't want to pick somebody you idolize because that might be too intimidating. And you need to be open to multiple mentors. They talk about a quilt of mentors in your life that help shape your pathway. And if it's connecting and clicking, then pour energy into it through emails, phones, meetings in person. They talk about one thing you got to be aware of: make sure that a potential mentor does not have selfish motives. You want to be the best researcher in this area. The mentor just needs a beast of burden that can clean up the lab and tend to the lab animals. So you got to be careful of that. How do you know you have the right mentor? Well, it should be a balance of challenge and support. If it's support only, that's like a cheerleader and everything you do is great. You really won't grow as much in that situation. If it's challenge only, over time, that sounds like criticism and can actually cause some regression professionally in the mentee. And the mentor should always be a role model for professionalism and ethical behavior. The mentee should never see them in a clinical setting having unethical behavior. So my first two real mentors in medicine were a husband and wife team in a little town of Cambridge, Ohio. In medical school, I wanted to be a general practitioner. And so I spent a lot of my senior year first in Cambridge and then Lancaster, Ohio. John Hahn was a family practitioner and preceptor for Ohio State. His wife, Melinda Hahn, was a nurse in his office. This is a picture of their home. It looked shabby. It wasn't shabby at all, but it was a little house and then a clinic adjacent to it. They just built right onto their house, and they had a family practice program. 2 weeks after I got there on a Saturday, we went around to 3 different high schools and did 500 sports exams, school exams for sports in the high school. Each kid had to pay $5. John, me, and his wife, and another nurse. At the end of the day, he paid the 2 nurses for their time. And then he had this shoebox full of cash. He divides it in half and gives me half of the cash. Now, up to that point, the only money I'd ever earned was mowing lawns. So for somebody to hand me that money for being a doctor was the most unbelievable thing I'd ever seen. And I've never seen it since. It was just such a remarkable individual that would do that. And it kind of validated what I was hoping to be someday, which was a doctor. While I was there, he said, "Oh, and we're going to run and get ready and qualify for the Boston Marathon." And I'd run in high school. I wasn't that good. But sure enough, every day in Cambridge for 7 weeks, we ran and we qualified. And a month after I left, the Hahn family and me and myself went to Boston and ran our first Boston Marathon. How do these relationships start and how long do they last? The initiation can be, most of the time it's informal. You see somebody you really revere and you kind of contact and a relationship starts. It can be formal, and Craig's going to talk a little bit about this. They have online validated processes where you submit your interest and then the computer at the university figures out the best mentor for you. The time frame on the average is 10 years in duration, but it can be very brief. It may be a key transition point in your career, and the guy just is right there. The man or woman is right there to steer you, and then you don't have much together after that. If it lasts longer than 6 months, then the mentee is most likely to start sharing personal issues. And if it's a sustained relationship over 10 years, then they become like a life coach for clinical research, life planning. It should evolve into a two-way street. The transmission of knowledge starts going both ways. The mentee should take advantage of that exchange and come up with new research ideas or facilitate a grant application. The mentor should take joy in the accomplishments of the mentee. It's like their kid. That doesn't always happen, but it should. Sometimes it doesn't evolve, and that's not a bad thing. It may be a mismatch of expectations. It may be the personalities clash. It's okay to move away from a mentorship relationship, try to do it gracefully and end on a positive note. So after I left, as I was getting ready, the last part of my medical school, I had to match. I had to put in for a residency program. And as my goal was to be a GP in a small town, but a family member said, "You need to go talk to Don Vincent." Don Vincent was the program director in medical education at a large private hospital in Columbus, Riverside Methodist Hospital. So I contacted him and he brought me in and we sat for a couple hours one afternoon and he listened to everything I was going to do and be everything in a small town in Ohio. And he said, "You know, that's a dream that a lot of people have. You're going to go to a small town, you're going to do medicine, you're for adults and peds, you're going to deliver babies, you might even do some minor surgery like gallbladders and hernia repairs." He goes, "But that doesn't happen. He says it has to be a crossroads for you not to have access to an obstetrician, for example, and you'll never be able to afford the malpractice or doing surgery. So you end up just doing medicine plus or minus a little bit of peds. And of course, nowadays we have med peds program. And something I had no idea about was if I went to family practice, I couldn't then decide to be a cardiologist or a gastroenterologist. Those were medical subspecialties. So sure enough, I went ahead and matched in internal medicine. Interestingly, as I was preparing for this talk a couple of months ago, I couldn't remember his name. This was over 50 years ago, 55 years ago. So I cold called Riverside Hospital and I got a secretary in the program office, internal medicine, and the call went something like, this is Steve McClave, and there was a guy in 1978 named Don, and he really helped me. Do you know who that would be? And she goes, well, I wasn't born in 1978, but she said, let me ask around. So she comes back the next day and she's got 3 names, and the first 2 names I didn't recognize. And then she goes, and the third was Don Vincent. I go, that's him, that's the guy. And when I had her on the call, I got online because I wanted a picture of him, and I couldn't find a picture. I found his obituary. He died in 2011. And I said, this is crazy, but would you just walk up and down the halls there and see if there's a picture of him? She says, okay. So 10 minutes go by. She calls back and she's all excited. And she goes, 30 feet from my desk is the internal medicine library. And it's the Don Vincent Library. And there's a portrait of him sitting in the library. And my point of this was he only had this position for 11 years. But here, 55 years later, he had influenced my career. He had influenced so many young docs in that hospital that they named the library after him. So my career deviated. Does that mean I dumped this mentor and went on to others? And the answer is no. Here I was, started my residency in Charleston at MUSC. And when I found that when I came home to see family in Columbus, Ohio, I'd always stop in Cambridge and visit with the Hahns. This mentorship relationship started to spill over to my siblings. 3 or 4 years after I left Cambridge, they called and said, okay, we're going to run the Columbus Bank One Marathon. And so I called my siblings. This is my older sister, my 2 younger brothers, Bill and Mike. These are part of the Hahn family, and we all ran the Columbus Bank One Marathon. And we all finished. They became role models for healthy life in their mid-70s. They switched to a plant-based diet and lost weight, got down to their college weight. Their parenting, their religious faith, their community service. At one point, they bought a van so that they could pull up to a field of migrant workers and provide basic medical care. In 1986, after I recruited UofL and got the bride in exchange, I called up and I said, I met this gorgeous girl from the phone company, and I've asked her to marry me. And they didn't even wait for an invitation. They said, what's the date? We'll be there. This is the kind of mentors they were. And it extended all the way up till this year. John died a couple of years ago, but at one point he left practice and became an administrator, a hospital administrator, moved to Lancaster, Pennsylvania, and then Tucson, Arizona. At the age of 67, we were both old enough that we were grandfathered and didn't have to recertify. But at 67, he said, I'm working with these doctors all day long. I better make sure I still got the same stuff. So he studied for and passed his family practice boards. At that time, I was walking around saying I'm a nutrition physician. And I said, well, if I'm going to follow his example, I need to study and take the National Board of Physician Nutrition Specialists. It's a very hard exam. I studied for it and got my boards. And that was just solely because of a mentor example that he set for me. This is a lifelong life coach, career coach. And I connected with his widow, Melinda, this spring. At the age of 82, she ran her last marathon. This year, she's mad at her kids because they took her bike away, and she's 86 years old. She's mad about that. You may not think of this, but there are 2 types of mentors. There are late career mentors and early career. The late career are people like Craig and myself. We've hopefully had a wealth of experience. We have less of a clinical load, at least for me, and more time to devote to a mentorship relationship. Hopefully it's a recognized name in the field. But don't discount the early career specialists. These are the ones that have less than 10 years experience, but they may be able to connect to the mentee on more immediate needs. They're going for an interview. They're applying for a job. They've got a grant application, and they're closer to that than an older mentor. This is an example of a late career mentor for me. Dick Fleming was a gastroenterologist at the Mayo Clinic. The alpha male for nutrition for us is a guy named Stan Dudrick that developed TPN at University of Pennsylvania. But immediately following were 5 individuals that created TPN regional areas for TPN, so that people with intestinal failure could go to these centers and receive life-saving therapy. And Dick Fleming was one of these 5. I'd been here in Louisville for 7 years when I got funding for a day-long symposium in nutrition and got to invite 6 of my dream experts across the country. We had the top renal nutritionist from California, the top indirect calorimetry expert from New York, and Dick Fleming was one of those 6. Of the 6, Dick Fleming stood out. He had the best talk. He was charismatic. He had been a minor league professional baseball player. He was kind and friendly, and we established a relationship just because of that day. 5 years later, here at Louisville, we published the first trial of enteral versus parenteral therapy in acute pancreatitis. Now, at the time, it was heresy to touch the gut in pancreatitis. So we came out and showed that it was safe. And then in the next year, several studies came out and showed that it was actually better outcome with enteral feeding. What was interesting is one of these 5 legends in nutrition became defensive. And it wasn't Fleming, it was another one. And they were defensive. TPN was their career. And here was this upstart from Louisville saying, maybe it's better to do tube feeding. He invited me up to his center for a symposium on nutrition pancreatitis. He spoke for 35 minutes. And at the end, he turned it over for 15 minutes for me to talk a little bit about tube feeding and pancreatitis. We were then on symposium together for the next couple of years. I always went first for some reason, and he would follow. And he would come up to the podium and he would tell the audience not to be lemmings. And after he'd done this about 4 or 5 times, I said, what is this lemmings business? And lemmings is that folk story or what, I don't know what it is, but it's the little rodents that run along and follow each other off a cliff and drown in the ocean when they drown in the ocean. So basically he was telling the audience not to believe anything I had just said. In contrast, the response of Dick Fleming, we were at our national meeting 2 weeks after this paper was published. And I was at a convention center on one of those big escalators, and I'm going up the escalator, and Fleming's coming down the other side and yells my name and waves. He runs down his escalator, comes back up, shakes my hand and said, that's a fabulous paper, and I think it's going to change outcome. This is an example of a phenomenal mentor that I met over one symposium. This was in March of 1992. In August of that year, he developed duodenal adenocarcinoma and passed within 2 months. And we just lost one of the best mentors. Now, I shared 2 of my late career mentors. There are 2 other guys I had to delete their slides because for time reasons. But if you notice, there's kind of a common denominator here. Look at them. They're all white, older males with white hair. Well, my hair's been white since I was 30. And at first I thought this was a problem with me. Maybe I don't believe in diversity. Maybe this is an exclusive boys club that I want to perpetuate. But that's not the case. This is a real important aspect of mentorship. You want to pick somebody that you envision in yourself. And I can't imagine being in an underrepresented group, walking into a meeting at a national conference or society, and you look around, there's nobody that looks like you, nobody with a similar background. And that puts the pressure on us to develop leaders in these underrepresented groups, women in medicine or nutrition, ethnic minorities, disadvantaged socioeconomic groups, international medical grads. It's very important that we represent these different diverse groups and create mentors for them. What's an example of a not so good mentor? This is a kid, my wife and I for years were counselors in our church here in Louisville. This was a kid that came through that program. His dad happened to be our head minister. This guy, Brian Grieve, went to Atherton High School. He's a role model for a mentee. Great kid, compassionate, smart, empathetic. And he now just started on the faculty in hematology oncology at Vanderbilt this summer. But when he entered the MD PhD program at Vanderbilt, he was assigned a faculty member that everybody knew was difficult. And they start out, they talk about these lab technicians, animal technicians that'll spend their whole career in one lab. They had 5 animal technicians in 3 years because the atmosphere in the lab was toxic. At the first year, he had a role model that he talked about every day with his mentor. At the end of the year, the animal model didn't work. And they had to start over. The mentor blamed Brian and said, it's your fault, the mentee. And he met with her every day. I called him in preparation for this talk and said, did you hate this person? And he goes, no. He goes, she taught me skills I wouldn't have gotten otherwise. He goes, and I said, would you work with her again? He says, I'd write a paper with her. I might exchange data, but she's tried to recruit me back to her lab, and I would never go back into that lab. So how you treat other people, the respect, the relationship is very important as a mentor. What about the mentee? Do they have any responsibility in this situation? And the answer is yes. A good mentee should take responsibility for their own learning, open to feedback, accept the support of the mentor, and infuse the relationship with energy, vitality, and inquisitiveness. It should inspire the mentor to go back and question everything they think about. Do you still believe that? Does that still hold true? And I think the most important thing for the mentee is to value and acknowledge the support of the mentor. So let me give you a couple examples. This is another kid you wouldn't know. His name's Tony Stiefvater. He went to Manual High School. He was in our church youth group. In the 7th grade, he would ride his bike 3 miles from his house over to our house, have a Coke with my wife, and then ride back. And at the time, he said, I want to be president of the United States. And I said, Tony, if you're going to be president, you'd have to be a lawyer, and that is a horrible career choice. So I got him steered away towards science. When he was a sophomore at Manual, he had to have a science project. And at the time, I did the only lab study in my career, and it was in Neil Garrison's lab at the VA. And we were looking at aspiration in relationship with gastric residual volumes. It involved this colorimetric microsphere. If I held up a vial, it looks like yellow liquid, but it's little plastic beads. And we put that in a formula going in the stomach, and then every 4 hours for 3 days, we'd go in and aspirate from the trachea, patients on the ventilator, and test for aspiration. 40 patients every 4 hours. We ended up with over 1,100 specimens, and there were 7 steps to each specimen. There's 2 ultracentrifuge steps. There's a mucolytic agent. The last step was to stick it under a fluorometer, and if it tested yellow color, you knew they had aspirated. The first day in the lab, we walked in, and there was another individual in the lab, Ryan Hurt, who went on to do his residency and medical school and residency and his PhD here. And Ryan was in the lab. So according to history, or at least their history, I walked in the first day, walked over to an expensive centrifuge and said something innocuous like, well, how's this puppy work? And they grabbed me and walked me out of the lab and said, I'd never been in the lab before. And they said, get out, we'll do the labs. So here's this sophomore in high school running all these specimens. He had guidance, Paul Matheson and Ryan. At the end of the study, we showed that 22% of these samples tested positive for aspiration, and it involved almost all the patients, 75%. We sent it off. It was published in Critical Care Medicine. I had no idea if it was accurate or not as a high school sophomore running everything. But a year later, a very sophisticated group, Maren Collis group at St. Louis University, used identical study, but used pepsin as their marker. Pepsin's only produced in the stomach. If it shows up in tracheal secretions, you know they've aspirated. And sure enough, 6,000 specimens, because there's only 1 step instead of 7, 31% tested positive for aspiration, and it involved 88, 89% of the patients. So he completely validated our experiment the year before. At this point, Tony was a senior at Manual, and we had our state nutrition meeting. And so we said, Tony, you should present this data. And on the program, it had Tony Stiefvater, MHS. So people kind of thought it was a Master's of Health Science, but it was really middle high school because he hadn't even graduated from high school yet. He went on to Center College, and his pre-med advisor was Joe Workman. And in contrast to my pre-med advisor, the botany doc, Joe works very, very hard with the pre-med students there. When he got accepted to MD PhD program at University of Cincinnati, they had a white coat ceremony. And it is very important. Your family comes up. Tony called Joe and I, and we sat right there with his parents when he got his white coat. 8 years later, he graduated, and he had to he had to present his PhD thesis. He called Joe and I again, and this time he added his 3rd mentor, Richard Lang, an ophthalmologist at Cincinnati. We sat in the front row. And before he presented his data, he points to the 3 of us and said, these are my mentors, and I wouldn't be here without these guys. So you appreciate that. Yeah, it's dumb, but we're human. And to him to recognize us at that point was just a wonderful feeling. He went on to Harvard Ophthalmology. He just finished in 2019. He is still a clinical professor at Harvard and doing research in Boston. This is an example of another good mentee, and this is Ryan Hurd, and Jen knows him well. He did medical school residency, chief resident. He is now the acting chairman of medicine at Mayo in Rochester. He embodies what I believe the Scout law. Now, he wasn't a Boy Scout, but I was. This is 1966 when I got my Eagle Scout. There I am sporting that president of the chemistry club look. The Scout law says a Scout is trustworthy, loyal, helpful, friendly, courteous, kind, thrifty, brave, clean, and reverent. And Ryan embodies every aspect of that Scout law. But the most important is loyalty. He is so loyal to his mentors that if you're around the two of us, and Jen knows this, he will say stuff like, well, I believe that because my mentor, Steve McClave, told me. And then a half hour later, it goes, Steve McClave told me this, and I believe it because he's my mentor. And it's kind of silly, but it really feels great to hear it. When he went to be on the faculty in Rochester, there was a woman there that ran the TPN program, and she wanted to retire, and she picked Ryan to take over that. So he had gotten 8 years earful of early animal feeding from me, goes to there and learns TPN from this woman. So he's incredibly well trained. But I play a game with him because he's so loyal. And I'll say, Ryan, and I don't think I agree with Dr. Kelly on this, or I think Dr. Kelly's wrong. And you'll just see the back of his head blow off, and he gets this cognitive dissonance because his two mentors are arguing, and he's so loyal to both of us. This is a phenomenal mentee. This is an example of the bidirectional aspect that develops with a mentee. This is Jay Patel, a pulmonary critical care doc at Wisconsin, former Nestle fellow. This guy works harder at the mentor-mentee relations than anybody I know. He still calls me at least twice a week. We've written 1 million papers together. Recently, a study came out and we started arguing about the benefit of nutritional therapy, how sick the patient is, and the likelihood of causing harm when we aggressively feed somebody who's really sick. And through the talk, I'm saying it's a bell-shaped curve. And he goes, no, it's a U-shaped curve. And finally, I realized we were facing two different aspects of this discussion. This is my interpretation on the right. And that is if you have a disease spectrum from mild severity of disease to severe critical illness, it's a bell-shaped curve. If you're not that sick, nutrition therapy, you're going to give it, but it's not going to change anything. And if they're too sick, you're still going to feed them, but the likelihood that you're going to alter the outcome diminishes. So somewhere in between is a sweet spot where feeding correctly and early, particularly with enteral feeding, you're likely to benefit outcome. That's different from his perspective. He was looking at whether we don't feed or we meet 100% of requirements and what's the chance of causing harm. If you don't feed at all, you have loss of gut defenses, microbiome becomes a pathobiome, harm is going to go up. If you start feeding by the enteral route, that harm diminishes and it flattens out between about 20 and 50% of requirements. But then if you keep pushing and the patient's severely ill, you can actually cause net harm, as shown by 2 different studies from France. So this was an example where we ditched the mentee-mentor. Well, I'm not sure I think he's flipped the wheels on me and now he's become my mentor. But this is an example where it becomes bidirectional, non-hierarchical. These are 2 colleagues now working through medicine. So why do we bother with mentorship? It develops the next generation of leaders for our society, for our university, for academia. It contributes to the growth and development of our trainees that come into us. It helps recruit and retain doctors in our society and our university faculty. It widens access to underrepresented communities. It creates role models to enforce and support diversity. It reinforces ethics and professionalism in what we do and ensures the practice of clinical nutrition. It enhances patient care education, collaboration of investigators, and as Craig is going to show us, it increases research output productivity. So in summary, mentorship is the ultimate win-win situation. It's the gift that keeps on giving. As the sign says, it takes a village. In my case, it says that because I couldn't find a sign that says it takes a province or a small city. But mentorship has shaped my career all the way along the line. If you find yourself in that relationship, pour energy into it because it will give you rewards ongoing. So I'm going to stop there and have Craig take over.
So Steve's a very tough act to follow. And we have a lot of very similar histories. Again, both grew up in Ohio, both ended up wanting to be family practitioners. And what I'm going to do today is talk about research resources at the University of Louisville related to mentorship. And a couple of weeks from now, John Klein is really going to go into this in a much greater detail. But in my disclosure, Steve got the Bistrian Award and he got to give a lecture. I got the Beckman Award and got a big cash award. So I'll take mine.
I'll trade.
So again, I'm going to talk about this new NIH grant called the CTRD Award. And it's over $10 million from the NIH and $10 million from the institution. And shown on the bottom are the cores, and those are the critical things. So this is really to build infrastructure and build the number of positions that we have doing research at UofL. So there's a community core on the far right, and a bioinformatics core that John Klein will talk about. I'm going to briefly discuss the professional development core and then focus on the one that I direct, which is the health resources core. So in the professional development core, it's directed by Max Boyacki and Ken Palmer. And the critical thing that I want to highlight about it is shown in red at the bottom. There's a 2-year Presidential Scholar Award. So that pays 2 years to support your salary for research. There's a whole host of other things that you can get to support mentoring and research. And so part of it amplifies existing programs that we have, and part of them are new. And I think certainly a lot of people know that we have different degrees in public health, like there's a master's degree in public health and translational research, but you have to pay for that. And so that's stopped people from doing that in the past. Now there's a source to pay for that. So that's fantastic. There's also the nature master classes that we're now paying for. And so you can go online and learn how to write grants, write papers. All this is free. There's a health resources core that Matt Cave and I direct, and it's got 4 aims. The first aim is to provide money for, as shown in red, these pilot grants. And so that's a 1-year award to basically help you generate data for a K award or a small R21 grant. The second one is a developmental project. And so that's 2 years of research funding. So we'd like to marry those awards with the presidential scholars that Ken Palmer has. And so that would pay then for your salary and your research. In aim 3, for people doing clinical research, we're hooking those people up with senior mentors that actually do clinical research, like Dr. McClave, Dr. Williams, myself, Dr. Sadlow. And lastly, we have a variety of systems to keep people out of trouble, which is important. So you have to learn about IACUCs, IRB, all that type of stuff. So in aim 1 to highlight, it's the pilot awards, 1 year in duration. We're giving 6 the first year and 4 thereafter, $75,000 a year. And importantly, it could be a fellow. So these are the first of these awards where you can go down into fellowship. You don't have to be junior faculty. The development awards are for 2 years. And again, that has to be a faculty, and it's $125,000 a year. And so again, we would like to marry those awards with the presidential awards. And so basically you'd have 2 years of support. The aim 3 again is to take project leaders and hook them up with senior mentors that do clinical research, so you get good mentoring. Aim 4 again is to keep you out of trouble. So I think we've got, for the first time at U of L, and I've been here almost 25 years, a roadmap for academic success. Dr. Williams actually started some of this with this CREATE Award that you can get as a resident. Then as a fellow, you can also get a CREATE Award or one of the IDEA CTR Pilot Awards. As a junior faculty, you can get a CREATE Award, an IDEA Pilot Award, or you can go to one of the other IDEA structures, like our Hepatobiology and Toxicology Cobra, and get a Pilot Award. Then for more extensive funding, you can get the IDEA CTR Presidential and Research Awards, and this will hopefully then move you into a K Award or R21 or an R01. And so this helps provide funding from basically residency to independence as a junior faculty member. Now, why is this important? So these are the most recent statistics from the NIH. If you focus on the blue over at the left, you see the numbers are decreasing. So this is the numbers of MDs getting NIH awards. So when I started out, it was way over 25%. When my mentor started out, it was way over 50%. So physician investigators are old, like Steve and myself. We're a dying breed. And so we need to repopulate the physician investigator pool. So Steve and I have a very similar mentoring history. I'll be a lot briefer talking about mine. So again, I grew up in a small town in Ohio. I wanted to be a primary care physician. There was only one in my hometown, and I wanted to grow up and be like him. I went to college, met my future wife there. And when I went to medical school, we got married. And so when we'd sit around the dinner table with her father, I needed something to talk about because we really didn't have too much in common except my wife. And so he was actually a world's leader in nutrition and kind of specialized area of nutrition called trace metals that I had never heard of before. Things like zinc, copper. And so I listened to what he said. And then in medical school, there was an incredibly charismatic guy. He was actually Elvis Presley's doctor, who was a gastroenterologist, and he stimulated me to go into gastroenterology. So I went to, as Dr. Williams said, the University of Minnesota, and we had to do a research project as a fellow. So I was still planning on going back to my hometown. But so I decided I'd try and do something in nutrition and see if some of the things that my father-in-law was seeing in mice actually worked in humans. So I worked with a guy, Leslie Zeev, who basically built the research system in the VA hospital systems and was the world leader in hepatic encephalopathy. And he had an instrument that would measure trace metals. So he was a magnesium expert, and so I wanted to measure zinc. So this was a atomic absorption spectrophotometer. My laboratory will never ever believe that I actually stepped foot in the lab. I did one time to actually do some of this work. And in return, I had to get specimens from hepatic encephalopathy patients and give them to Dr. Zeev so he could see whether his animal work actually translated to humans. And so we formed actually a great working relationship. I learned tremendous amounts of things from him, like how to build a program, how to deal with difficult people, how to write a grant. And actually, I became the youngest head of GI in the country. I went to University of Kentucky at age 36. I was the youngest head of the American College of Nutrition in the 1980s and described a lot of nutritional deficiencies in humans like zinc deficiency. So a whole different life. The smartest guy in medicine and that I've ever met in research, and Steve McClave will agree with that, is Mike Levitt. And this is a picture at his farewell party in his 90s. So he's Mr. Gas, Mr. Fart. So he described why farts smell. But he also worked with NASA, because it's important when you go out into space that you don't have your capsule filling up with bad smells, and how do you deal with going to the bathroom. He dealt with the unstirred layer in the intestine, which is the most mathematically complicated thing you can possibly think of. Mike was a brilliant guy, would always come up with a unique question. And so I learned from him basically how to read other people's grants and how to come up with the right question to write a grant. The last person's my dad. So Steve and I have shown a lot of runners. So this is my dad running a triathlon in his mid-80s. So he basically spent his career in a small town in Ohio doing a lot of good. And the thing with that is it turns around and comes back to you. So when my dad turned 100, we took his car keys away, but he was able to live on his farm because all the good things that he had done in the community turned around. People came back, picked up groceries for him, took him to church. And so he was able to live 2 years independently because of that. And mentoring comes back to us. So, you know, I've written over 500 papers. 501 doesn't make too much difference. But having one of my mentors call me at Christmas and talk to me is a great thing. And so as you get older, those are the things that you'll appreciate. So when we're done here, there's a mentoring symposium over at Research Louisville. Mentoring is a fantastic thing, and we encourage you to get involved in it, and we'll see if there's any questions. Thank you.
Well, this is really tremendous. It's good to hear more about you, gentlemen, and how you've developed. And I do want to ask a question about what Steve brought up, which is how do you break that cycle of mentorship of, you know, C1 and B1, mentoring people who look like you and trying to change that dynamic, and where do you go to do that? But before I ask that, I just have to compliment Steve. You know, you went through that whole thing, and I know I love alliterations, but for you, it was the nameless negative role models and the nameless naysayers. You never actually said the name of anyone who did wrong. So that's the true definition of a gentleman. But back to the mentorship of people outside of that circle. How do you do that? Because I know you're doing it and you're doing it well. So do you try to find college? How do you do that?
So if you look at the pictorial that I had of this new grant that we have, so we've pulled in people. So basically almost half the leaders are women. Max Boyaki is obviously an African-American. So it doesn't happen overnight, but we obviously have to get more people than old white guys like Steve and myself. And but it starts actually at manual. So, you know, you need to get kids in high school and get them involved. And so we actually have a pipeline for doing that now. Steve?
A couple of reactions is just to be flexible in how you interact with young people. How you speak with them, how you listen to them. You should never get a point in your career where you think, I've learned it, I'm there, and now I'm gonna just tell everybody how to do it. My biggest struggle is for somebody to come with an idea for me, and the first thought that jumps in my head is, oh, we tried that 10 years ago. It's not gonna work. You can't say that because it's 10 years later, different people, different issues. It might work this time. So how you react to that information. The other thing is be comfortable not being a mentor anymore, but on an even keel and even being a mentee. In that lab where they kicked me out because of my attitude toward the centrifuge, I said, well, okay, I'll just be the guy that types up all the data. So Ryan and Tony gave me a 10-minute evaluation of my typing. Immediately I was thrown out as the typer because I typed too slow. So being comfortable with the shifting plane and just investing in the relationship, and then both grow in that direction, in a good direction.
Thanks. Other question? Dr. Sadler.
I just want to pay a tribute to all you young people back here. I've known Steve for 3+ decades, Craig for a couple of decades. And these two individuals, research and academia, are some of the main people that have put University of Louisville on the map. But then also you have people like the Honorable Paul Brown, who is just as distinguished in the clinical field, working 12 to 16 hours, 12 days in a row at Audubon, St. Mary's, downtown Norton's Jewish, which that's where I met him in the 90s. So you've got some really mentors here to look up to.
Right after I first got married, we moved into a new house and the movers were there and I'm supposed to be helping them. But I was up in an empty bedroom with Paul. Paul was finishing his fellowship. We were writing out an abstract to go off to our national nutrition meeting. And my wife's getting a little upset. She just met Paul and he's hogging me and not helping to move. So that relationship goes way back to both of us.
Fantastic. Jason, do we have any questions online?
Nothing on the chat, but just praise for this talk. So
Fantastic.
Really,
All right. Well, thank you, gentlemen, very much.